Thank you very much indeed, Mark. You couldn't have introduced things better for me. First of all, welcome to the Women and Children's Domain. I'm the academic lead, Peter Clayton, and Ian Jacobs mentioned right up front that we changed our name. We were the Human Development Domain, and we are now Women and Children. And one of the primary reasons for doing that is to ensure that everybody in MAHSC and everybody outside MAHSC across the UK realised who we were trying to make an impact on, and that was women and children. Now, those of you who've been listening intently, and that's everybody, will recognise that women and children have been mentioned quite a few times already this morning. So I think that my first point, across the 6 domains, there's a lot of crossover, a lot of opportunity for collaboration and cooperation. Then my next point is that across our partnership, there are a very large number of healthcare professionals who work with women, children, mothers, and families, and they are embraced by our domain. And within our domain, we have the Manchester Genomics Centre, and you will also, it will have not escaped you, that genetics and genomics has been mentioned a number of times this morning as well. And the Manchester Genomics Centre is able to not only support the work that we do, but cross-cuts across most, if not all, of the other domains, both supporting and leading work that they do, and this agenda that you heard right up front about personalised medicine and the introduction of personalised medicine. So in a minute, Alex is going to take you through a particular pregnancy disorder. But our Maternal and Fetal Health Centre works extremely hard on disorders of pregnancy. Their goal is to take a woman with those disorders through pregnancy in as healthy a way as possible so that she delivers a healthy baby. That healthy baby grows up to be a healthy child, teenager, young person, and adult. That focus on early life course is absolutely the what underpins all of the health issues that you've already heard about. I'm just going to do one little focus on children's research. We have a particular focus in MAHSC around rare diseases. And I'm going to share with you a video from parents of a baby with a rare genetic condition with an enzyme deficiency. And if we could start the video so you can listen to what these two felt about their treatment.
Ava, our daughter, was diagnosed with an extremely rare metabolic disorder. From the time she was diagnosed to the time we actually left Ireland to come to Manchester to start the treatment, she deteriorated an awful lot. She just wasn't herself. I say she only had days left before she started the trial, and without the trial she definitely wouldn't be here.
As the days went on, we could see, both myself and Aoife as parents, could see Ava becoming, just getting worse.
With the trial, I think we didn't know what to expect. Nobody could give us any definite answers because it's a trial. Nobody knows what the future holds. But thankfully it has worked 100%, and she's having no reactions, thank God. And she's just doing very, very well, and she's putting on weight, and she's learned to walk, and she's doing everything she should be for her age, and she's happy.
I always say to Aoife, Aoife on the 26th of September gave me a beautiful baby girl, but I just say Manchester Hospital, give her me again. What we could do as a couple, we could never repay that because they give us our daughter.
Okay, so my particular thanks to the Royal Manchester Children's Hospital charity for the Children's Clinical Research Facility, and for Simon Jones and his metabolic team for allowing us to use that video, which I hope you'll recognise illustrates just how important the impact, even in a rare disease, of a treatment such as this can make. And Mark, you were asking earlier on about getting research findings into practice. Well, these sort of trials can lead to fast tracking of drugs that can then become available for clinical practice. Okay, so we have a question for you.
I've been talking. Quiz. I love a quiz.
I've been talking about rare diseases. So, what do you think? How many people in the UK have a rare disease? A to D. Click away.
When does it become rare?
Some interesting numbers we've come up with here. So have we got a result yet? Oh, might have to press something. Right. Okay. So, 1 in 57, but there's a bit of a spread there. What is the number? Actually, for those of you who are really sharp-eyed, it's in your brochure. 1 in 17. Doesn't sound so rare, does it? So, there are actually 7,000 rare diseases, and although each disease affects 5 people or fewer in every 10,000, collectively, they affect 3 million people in the UK and 30 million in Europe. And if you put all of the people together in the world who had a rare disease into one country, that country would be the 3rd most populous. 80% of these rare diseases are genetic in origin. And 75% of people affected by a rare disease are children. Okay, another quick question. How many of the 7,000 rare diseases have treatments? Okay, A to D again. Vote away. Okay, quite a spread again there, but we're going for 400, and you're absolutely right. So there's a long way to go to generate treatments for all of those diseases. This is a little bit of a salutary fact at the top here. 30% of children with a rare disease die before their 5th birthday. And fewer than 50% of these rare diseases have organizations that will support or conduct research in that particular disease. And the government, as many of you will be aware, are going to provide support to look at the genomic testing within 100,000 people, a portion of whom will have rare diseases. And of course, over in the Children's Hospital, we have facilities in order to develop treatments, and you heard one example earlier on. We have the Children's Clinical Research Facility. So, in our patch here in Manchester, 3.9 million people. 1 million of those are under the age of 18. When you do the sums, that's 45,000 with rare diseases. 12% of the population in Greater Manchester are South Asian, and there can be a concentration of rare disease in those groups. And you've heard some of these facts before. 36% of children in Manchester living in poverty, high teenage pregnancy rates. So I'd like to finish there and pass over to Alex. These are our objectives. Over on the right-hand side here is to increase our reach out to obstetric units to get them involved in research studies. Alex will tell you about stillbirths. And in the middle there, our aim is to drive mainstream genomic testing into the NHS and to offer children with rare diseases the opportunity to be involved in research. Alex, over to you.
Thank you very much, Peter. Is there a... thank you. As Peter said, I'm Alex Heazell. I'm Clinical Director of the Tommy's Stillbirth Research Centre. And this is one outcome of pregnancy that we obviously want to avoid, if at all possible. And we've spoken about rare diseases, we've spoken about other problems that are perhaps taboo, things that aren't spoken about. And up until recently, stillbirth has definitely come under that bracket. So I want to ask you how frequent you think stillbirth is. So in the UK, we define stillbirth as the death of a baby after 24 weeks of pregnancy. So amongst our sort of financial competitors, how frequent do you think stillbirth is? So it's quite a spread of data. Interestingly, there's some optimists in the room who think that we do as well as Scandinavia, and we might well do because we have an organised state-based health service. But actually, sadly, the answer is D. 1 in 200 babies are stillborn after 24 weeks of pregnancy in the UK every year. And it's been something that we've been very keen to address. There's been a huge research gap in this field. In fact, there are only about 6,000 publications on PubMed on stillbirth, in comparison to over 800,000 on pregnancy as a whole. So it's even not particularly considered within the pregnancy field. And here you can see that the top red sort of bar, that's us there. And perhaps the other really interesting bar on this chart is green, which is showing quite a considerable drop, and that's actually the Netherlands. And in the Netherlands, they've really taken stillbirth very seriously, and through perinatal mortality and units working together, they've managed to actually cause their stillbirth rate to fall by 20%. So how do we fare in Greater Manchester? Well, we have a population that has a number of risk factors for stillbirth. We know that poverty, black and ethnic minorities are at significantly increased risk. And you can see there Greater Manchester lighting up quite dark green with higher prevalence. You could argue that a middle-aged white male is probably not the right person to tell you about stillbirth rates and stillbirth in Greater Manchester. Because actually a number of the things that we need to address are within communities that perhaps we're not always good at reaching. So we've said how common stillbirth is, but how does it compare to other problems that we're quite used to dealing with in obstetrics? Do you think it is more common than Down syndrome? The same as fetal anomalies, neonatal deaths, or cot deaths? Only one of those lists is more common than stillbirth. Which do you think it is? Well, you are absolutely right. 47% of you guessed right. So fetal abnormality is the only one of those that is more common than stillbirth. And one of the interesting things and challenging things about talking about stillbirth to parents and to patients is that there is quite an underappreciation of its frequency. And we're quite used to talking to parents about cot death, about putting babies on their back to sleep, but we don't have similar health promotion messages for stillbirth. So something is, why haven't we taken it seriously in the past? Well, it's now becoming even more recognised, and recognised through the work that's being done here, that it has the same impact on families as any other child bereavement, but it's frequently missed. And as I said, there's a strong link with things that perhaps as health professionals we feel unable to do things about. So deprivation, women from black and ethnic minorities, smoking and substance misuse. But actually, the three major conditions we have very strong pedigree for, so particularly babies suffering from fetal growth restriction, where the baby doesn't grow to the extent it ought to in the womb. And Manchester has over 40 years of pedigree and research into this condition. And so what are we trying to do? Well, we've set up a clinic to try and develop and start interventions to reduce the risk of stillbirth, and combining the understanding that we've generated from basic science studies, learning how to prevent stillbirth, and improving care by providing continuity of carer and psychological support, and directed and frequent checks for complications. And a lot of families don't fit, perhaps, the picture that you might see of bereaved families. And we forget that it has an impact not only on the mum and the dad, but also on the siblings, on grandparents, on wider families. And this is a family that we cared for in our Rainbow Clinic. And it hit me how important it was to the siblings of these babies. Each of them came to one of the different scans to see their new brother and sister, because last time they didn't get to see their sibling. And the most encouraging thing is that it works. Since 2011, we've seen a 19% improvement in our stillbirth rates. And if we were able to repeat this across the whole of the Northwest region, we'd see 50 fewer stillbirths a year. So there's a real opportunity there to save babies' lives. And just the impact that makes, you'll see through this film, we're able to provide a continuity and depth of care through the service we provide.
We knew the birth would be quite complicated and the pregnancy was quite complicated. But at 28 weeks, I had a placenta abruption, a blood clot behind my placenta, and had to have an emergency caesarean section, and Scott was born at 28 weeks. Unfortunately, he spent some time in neonatal intensive care, but he sadly died because he was born too early and too poorly really to make it through. So, yeah. I had a named midwife, just one person who I dealt with, and I could ring at any time. You know what? They've spent an hour at a time more on the phone to me, talking through things that I've been worried about, and you never felt like that they had any limits on their time. And I was given a lot of care and attention, really. The other thing that I found really helpful was something very small that the clinic did. They put a rainbow sticker on your notes. So if I came into the hospital for any reason, or perhaps came in to triage, then the staff here would know immediately that there was a history, and that I'd had a baby who died. And do you know what? That was really, really helpful. I was always treated in a very personalised way. It was very specific to my needs. So at 28 weeks, when I had the placenta abruption in the first pregnancy, I was given extra scans, I was given extra tests, I was given a lot more reassurance. And that was amazing, really, absolutely amazing. And when I started going to the Rainbow Clinic, I wasn't ever sure that I'd walk out of the hospital with a baby. And as the weeks progressed, they started to make me believe that was possible. So when I left hospital with her, it was a very big thing. Celia was born on the 23rd of June this year. She is quite a determined little girl. She likes to stand on her feet, roll over. She wants to do everything right now, don't you? But she's absolutely beautiful, and we feel very, very lucky to have her.
We're very fortunate to work within a multidisciplinary team, an environment that encompasses the translation of research into practice. And so thank you very much for your attention.
Okay, round of applause. Thank you very much. Thank you to Alexander and to Peter. Peter, I've got one question for you, because it just strikes me that there was one statistic that you had in a slide there, and I just thought this is extraordinary, is that less than 50% of rare diseases have an organisation to support patients or conduct research. Why?
Well, it takes a great deal of effort for families to come together to generate a support group. Obviously, some of the rare diseases, there are only very few, and actually the support group needs to be international rather than national.
We have the internet. Yeah.
We have the internet. So over the last 10 or more years, more and more groups are coming together. And even some of the newer groups, they may not have formed into actually a full support group, but they may have a chat room on an internet site or whatever. So I think it's something that we're going to see more and more of, and those groups drive agendas.
Yeah. And I was wondering about MAHSC's role in this, actually. I mean, if there are areas, perhaps there is a support group, but it's not very good, and actually MAHSC can be the link between the practitioners, between the researchers, and those support groups.
No, I think it's a very important part of MAHSC's work to reach out and to help to facilitate that type of activity.
Absolutely brilliant stuff. Thank you to our final domain.